Healthcare and senior care is fraught with problems and challenges, but we're also seeing some amazing new clinical treatments and resources. This show will help illuminate and uncover the good, bad, the ugly in order to equip patients, families, and other healthcare providers. Welcome to Senior Care Confidential.
So Leslie, we are without Jo today. She's celebrating Grandparents' Day in Ohio. And so, we've been teaching this hospital-acquired frailty, what we call hospital-acquired frailty in a lot of hospitals and rehabs. It's really the cascade of dependency. Mm-hmm. And one of the folks that I got connected with, as you have too, is Dr. Kali Dayton. And she has this amazing program that is, I think it's called Awake and Walking. She'll correct me in a second, from the ICU. So, it's one thing to pay attention to immobility for just our normal med-surg patients. It's a whole other ballgame when they're actually in the ICU. Like the stakes are much, much higher. Right. And so we were so happy to get connected with Kali. And so Kali, welcome to the show.
Thank you so much for having me.
So I know your background was you're a nurse practitioner, doctor of nurse practitioner, and you were an RN working in ICUs to begin with, right? So walk me through that history of how you started with that and like where are you now?
In 2012, I had my license for 3 years. I was interviewing into my first ICU job, and the nurse manager asked me, "So would you be willing to walk intubated patients?" It was very abrupt. It was one of the first questions. I look back now and I'm like, if I had said no, that I was not willing to walk patients that were on a ventilator with a breathing tube, I would have been kicked out of the office. I think the interview would have been over.
Right.
Fortunately, I said yes because I didn't know anything else. And I said, you're going to have to teach me everything. And as I worked in that high acuity medical surgical ICU in 2012, almost every patient was awake right after the procedure of placing the breathing tube, writing on a clipboard because they can't talk. And within 12 hours after arriving to the ICU and or getting the breathing tube placed, they were walking if that's their level of mobility they could do. If they could only stand and pivot to the chair, that's exactly what we were having them do, even with the breathing tube. So that was normal for me. Didn't know anything else, didn't think anything of it. I enjoyed having very human connections with my patients. I loved seeing them work hard for their own lives, walking around the units with the breathing tube. After a few years of that, I became a travel nurse, and I was very shocked to find that in all the other 11 other ICUs I worked in, no one else did that.
That's what I was going to ask you. Was that a unique experience in that particular hospital where they were doing that? Because I have been a therapist in acute care and I've not seen that before.
Yeah, I just assumed it was standard practice.
Right. This is normal. When I
got, it's normal. I was like, hang the antibiotic, titrate these medications, and take your patient on a walk. Whatever. Just another
no matter
day.
how many tubes are sticking out of them. Yes. Yeah.
I, as a nurse, walked patients around the ICU that had a breathing tube on a ventilator without PT or OT there on night shift.
Wow.
It never occurred to me that I would need the therapist to do something that was within my scope of practice.
Thank you.
If they were walking well around the unit during the day and they already walked twice and they're sitting in the chair, I'm going to take them around the unit one more time. And if they couldn't walk, then I'm going to sit them at the side of the bed. We're going to stand at the side of the bed. We're going to do something to engage their muscles to wear them out so that they could sleep throughout the night. And that's how I'd get my quiet night as an like on night shift, right?
Gotcha. Okay.
So my theory was, I'm going to wear you out before you wear me out.
Right. We do it with kids too. Yeah.
It was just, it made sense. Yeah. And so I was just really confused why that was not common practice elsewhere. And I would ask what people perceived as stupid questions when I would ask questions like, why are they sedated? Why do we have this drip running?
That's interesting.
And they would say, because they're intubated.
Right.
So for them, the only reason, or to them having a breathing tube, that alone was reason enough to be comatose, to be sedated, to have the same kind of medications we give in the OR for a few hours. We now give that for days to weeks just because they have a breathing tube. That was the first time I had been introduced to that very concept. But unfortunately, I didn't know the risks of that. I didn't know what those medications were doing to the brain, to the muscles. It felt weird, but I met such resistance. And I was only 2 years into my career. And as a travel nurse, you don't want to be the nurse that's like, well, in my unit, here's what we do, because you automatically
Right.
get,
You're
like,
that one.
blacklisted.
Yeah. Yes.
So I just thought, well, if everyone's doing it, it must be okay. What's normal must be benign.
Yeah.
So I did it for 2 years. And then I went back to the wake and walking ICU during grad school. And I almost had another layer of shock. I had gotten so acclimated to having patients comatose. And in my mind, they were like deconditioning zombies in the bed. I didn't know who they were. I saw such poor outcomes, lots of tracheostomies. Nobody walked out of there.
Yeah.
I'd gotten so used to that coming back to that first ICU, recognizing how sick these patients were, yet how human they were, how well they did, how fun they were to care for, how successful they were, totally made me question everything I'd just done the past 2 years. And that's what made me look into the research. And the more I discovered about the reality of these normal practices, the more I realized I should have known that. And these other clinicians that I worked with in these 11 other ICUs did not know that. And if they did, if they knew what we were doing here in this awake and walking ICU was possible, they would absolutely do this.
Yes.
They just never learned it.
Wow. Now, are these the 11 other ones that you did the travel nursing with? Were they, or any of them part of the same organization that you came from? Or was your hospital like a independently owned one and that's why it was run differently?
It's a great question. It's one hospital of many, and a multi-hospital system, very large system, regional system. It goes throughout many states. And they've been doing this process since the 90s. During
This
grad
one
school,
hospital.
One hospital of many. And that hospital was smaller. It only had one ICU, yet it was a high-level hospital. It had one of the highest acuity COVID units in that state during COVID. We would receive the same patients that would go to the huge hospitals. They would go to our hospital during COVID and other times of its history as well. So working in the float pool during that system during grad school was really conflicting. I'd get whiplash. So I'd work in my wake and walking ICU, one shift. The next shift, I'd work in a normal ICU. I'd be walking critically ill, multi-organ failure, septic shock, ARDS patients there. And then I'd go to another ICU where patients should be off the ventilator, and yet they won't let me take sedation off, and they especially won't help me mobilize someone. It was very, very conflicting for me.
Yeah, I bet. So when did you start? So you finished grad school, and at that point, did you go right back into the awake and walking ICU, or what was next step after that?
I knew that I couldn't work anywhere else.
Yeah.
I knew I had to be in an environment that will let me continue to learn as a new nurse practitioner, and where I knew I could be a part of the best care possible. So I went back to the ICU for a few years, and late 2019, I wanted to move my family up to where I was from in another state in Washington. I interviewed at a hospital, and I knew I had to be true to myself and ethically be honest about where I came from and what I was determined to do with my patients. And so I said, the greatest value I can add is to help you keep your patients awake and mobile while on a ventilator. And they looked at me like I was speaking French with two heads.
Yeah.
And they said, you can't do that. I said, I can't mobilize intubated patients, or I can't teach you guys how to do it. And they said, what do you sedate them with? Like, they didn't even know what I was talking about. They couldn't even imagine patients being awake, let alone mobilizing on a ventilator. It was very uncomfortable. It became very clear that they were not open to learning anything different than what they were used to. So I didn't end up working there. But it kind of was one of the drops in many buckets. God told me shortly after that, start a podcast. Didn't know what a podcast was. I'm a poor excuse for a millennial. I'm not very technologically savvy. And yet I just couldn't shake this very clear revelation. So I would wake up in the morning and have to write down instructions. And I knew what episodes to do in what order. I'd run across survivors. I'd interview my colleagues. And I did 32 episodes in like 2.5 months. Put those out beginning of March 2020, and then COVID hit. And little did I appreciate that this would be so important for COVID, but a very hard time to implement these things. And yet I kept going down the rabbit hole. I had more questions. There's so much I didn't understand about why this works. What does the research show? what does it take to make this? Because I worked in this idealistic ecosystem, but I'd never been part of changing a culture.
Mm-hmm.
And so now I'm almost at 200 episodes in to this podcast. I've found a lot of answers. It's become a whole movement of revolutionists trying to revolutionize culture and practices in the ICU to keep patients as awake and mobile as possible.
What do you think is the top 2 or 3 reasons why the ICU that you worked at, the Awake and Walking ICU, is such a rare find? Like, what is it about these other, like even within the same major corporation, there were other hospitals that did not function like the one that had the Awake and Walking. What are like the top 2 or 3 things that you see that are the things that make it difficult to change back to that or to that?
Think of, on the surface, you see practices, but underneath are the roots of culture, and even deeper down roots are knowledge, training, beliefs, perceptions. So in the 1990s is when we really started to standardize medically induced comas for every patient on a ventilator. We were experimenting with how to manage patients with really sick lungs with ARDS, and we were giving them way too much volume and pressure from the ventilator. So they were popping lungs, they were getting pneumothoraces, and patients were so uncomfortable. They couldn't just be awake and comply with the ventilator. So that's when we brought up medications from the OR. And the initial goal was to get them to comply with the ventilator. But what we, and especially nurses, saw was that their eyes were closed and they were still, and they were just laying there. And the perception was that they were sleeping. We knew that it caused amnesia during surgery for a few hours. What we didn't appreciate was the damage that it does for a few days to a few months or weeks. But that perception that patients were sleeping, that this was more comfortable, humane, safer, easier, all of those things
They
spread
seemed
like
at peace.
wildfire.
Yeah, I mean, any ICU nurse will say, if I'm intubated, I try to talk to them, right? And they're like, don't keep me awake if I'm intubated.
Yep.
It's hard to have that conversation, much less, that's amazing during that time.
Certainly it's not comfortable to have a tube down your throat with a leaf blower slamming air into your lungs, right? But I think the reason we say that in our ICU community is because of what we see when we turn sedation off. When we start sedation, we disrupt the brain activity, we deprive the brain of sleep. So if you think about how you feel and act and think after 24, 36 hours without sleep, some of these patients have gone 5, 7, 14 days without real sleep. Their brain is so damaged.
I'm going to stop you. Go back to that. Because the assumption is when we're sedated, we're in la la land sleeping. Are you saying that is not the case? This is like sleep deprivation when you're in sedation?
It's impossible to get real restorative sleep. You cannot go into REM cycle 3 and 4.
I had no idea.
I didn't either until
propofol.
Kaylee. Yeah.
Wow. I did not know that. Okay. And we know there's a sleep center about every 100 yards here in Dallas, because there's a big focus on sleep now being, hey, this is like the number one thing that may be causing some of these chronic illnesses. And so sleep is a big deal. And so, wow, I had no idea that if you're sedated, you actually do not get normal restorative sleep. It's like counter to what I would have thought. Because you walk in, patients on our ICU, a sedation, and they look like they're asleep. Everyone's peaceful.
They look comfortable.
Yes. Wow.
And then when you turn sedation off, well, under that guise of sleep, what they're oftentimes experiencing are graphic, vivid, traumatizing hallucinations.
Oh, interesting.
I've interviewed dozens of survivors, and they're talking about think that they're kidnapped, that their kids are kidnapped, that they're being cannibalized by their deceased father, that they're living their worst wartime traumas, as well as all the stories they heard from their comrades. They think we're trying to kill them. I mean, just the worst things. So when you unmask that terror by turning off sedation, you think about sedation as a chemical restraint. It's just making it so that they cannot move. Their brain can't tell their muscles to move. So you turn off sedation, now their muscles can move. Now they have so much brain damage having happened, and they're so delusional, so confused and terrified and fighting for their lives. They think it's a snake down their throat. So of course they're trying to pull it out. So clinicians see that. They see sedation on, sleeping, peaceful, comfortable. Sedation off, uncomfortable, distress, pain.
And the family at the bedside seeing that. Don't forget that part.
It's so stressful. And no one explains to the family the risks of sedation, what's going to happen when you turn sedation off, why they're responding that way, how to help them, because clinicians themselves don't know.
We don't know. No.
Do you think a reframing of sedation to chemical restraint can be beneficial? Because when we think of sedation, we think of sleepiness and peaceful. But if I call it, we're going to give your mom a chemical restraint now, I'd be like, hell no, you're not.
I know nurses that have documented that as such and have gotten in trouble for it.
Interesting.
But that is accurate.
Okay.
It's how we document when we have them in restraints because they're chemically restrained. So, because you have to do vital
and some
signs.
Some ICUs are very into avoiding restraints because we know it can contribute to post-ICU PTSD. But a lot of it's because they're confused and tied down, and it feeds into the terror.
Right.
Yeah.
But instead of physically tying them down, what we find is they actually increase sedation. So they can't move a muscle.
Oh, yeah.
So you're not protecting them from PTSD. But it's well intended, but poorly executed.
Oh my gosh.
In the ER, I would try to get them down far enough before, because we had a program where we would get them out of the ER into the ICU as quick as possible because that showed better outcomes.
Oh, there we are.
And I'm not even sure what those outcomes, what they were, but they told me that, right? And so I would try to sedate patients as quickly as possible by turning it on high rates. Because I don't know if I should tell on myself or not. Like you talk about things that you regret, right?
Yeah.
After reading a lot of the things that you kind of post and talk about, the titration was not specific whether we could titrate up or down. And so we would titrate from high down to low until the patient could tolerate it to get them under, right? So now I want to thinking
you
about
can't blame yourself. It's ignorance. It's not knowing.
It's what the culture taught me to do. There was a nurse who literally said, hey, the titration orders don't say, start low and then go high. Like, let's start high. And because if not, then they're fighting the restraints. And then you've got more staff on this one-to-one patient than you can afford in the ER, and you're about to transport them. And so you don't want them to be unsafe with that ventilator that you're in charge of after the doctor has placed that tube. That's your tube, and you're breathing for them and you're life sustaining for them. So, okay, I'll stop.
Wow. Yeah.
And, for short periods of time, again, like procedures in the OR, sedation's great. That's what it's for. It's when that patient now goes up to the ICU and no one revisits that sedation because I looked good on that high dose. So I'm not going to rock the boat. They're sick. Now, ironically, that sedation oftentimes lowers the blood pressure. Now we have to give more medications to raise the blood pressure. And a lot of times they'll say, well, they're so sick. Look how much blood pressure medication they need. Let's not turn sedation off because they're so sick. When really, maybe it's just the sedation that's causing that blood pressure.
Yeah. And I know,
so much support.
I know in hospitals, there's a doctor here, a local doctor that has we'll call it a delirium unit or an anti-delirium unit. And so he's real careful on the sedation piece of it because of the impact of sedation on delirium. And I know one of your recent posts, you talked about that continuous sedation increases the risk of delirium by 214%. And if they're on it for over 7 days, the risk of delirium is over 3,000%. And now I don't know if that correlates with other studies, but I've seen other studies where I always say hospital acquired because I'm bound to determine that this is going to stick. Hospital acquired delirium is roughly 50% of those, when we're talking seniors, of those seniors that experience delirium while in the hospital will have long-term effects of that.
Yeah.
Like 50% of them will recover. The other 50% will have long-term downstream effects from having delirium. And so we're talking 3,000% increase in delirium by being sedated in an ICU. That is incredible numbers.
If they're over the age of 64, they're 4 times more likely to develop delirium, period.
Yes.
Once someone has developed delirium, they're at 120 times greater risk of long-term cognitive impairments that we call post-ICU dementia, regardless of age. So even young people come out with these brain injuries, but it's far more detrimental to have that happen on top of baseline dementia, aging brains, things like that. So it's life-altering. It's also life-ending. It doubles the risk of dying.
Yeah.
1 day of delirium increases the risk of death by 10%. But we're not panicked about it.
Clearly.
We respond to it.
Well, they seem like they're at peace. So we'll just keep them peaceful.
Well, it's easier for a nurse too.
So when you go in, so now you have an organization now that goes around the country and teaches hospitals on this. I'll call it the Awakened Walking program. I'm not sure what you call it when you teach it. Is that what you call it?
Awakened Walking ICU.
It is okay. Awakened Walking ICU. So you teach this around the country in a bunch of ICUs. When you first go in and you start talking to them about like sedation and these other things, are the nurses and like the executives' minds just completely blown? Like, holy crap, this is we've been doing this for so long. Now we're learning that this is actually bad.
Right.
Yeah. It's a very sensitive thing to broach because you can't fix what you can't confront. I don't have a lot of time. I have to dive in and just say, here's the reality. Here's where we're at.
Right.
But I also don't want anyone to be burdened by guilt to where they can't function. I want to leave it on a positive note because it is exciting to say, look how much harm we can prevent. Look how powerful our interventions can be. Look how much good we can do.
Yep.
But in order to get there, we have to recognize that what we've been led to believe is normal is actually very, very lethal and dangerous and actually burdensome to the nurses. So delirium, for example, increases time in the ICU by 4.47 days, time in the hospital by 6.67 days. They're 3 times more likely to come back to the hospital. So when we're talking about a staffing crisis, it doesn't make sense to have a delirium factory. These are not fun patients to take care of when they're confused, impulsive, trying to get out of bed, falling, pulling out lines and drains.
We just sedate them.
We just sedate them.
We give them some chemical restraints.
I do think that's some of the mentality still, right? With hospitalists who that's what we've always done. We call them, we get chemical restraints because the patient's going to harm themselves or they're a hurting staff member. But so I saw you cringe when I said it's less work for nurses because I don't think that anymore, right? Because I've watched the delirium unit at the hospital that I worked at be so successful. These patients, we were keeping them from going into delirium or getting ahead of their delirium where they had a space to move and to be mobile, and the medications were pared down so that they didn't have, that delayed factor of the liver not processing a lot of these that just get stuck in the system, But so one of my biggest questions, and maybe we're jumping ahead, but we're talking about nurses, is how do you talk them into this? Because the culture is, the joke is, right? I'm talking to an ICU nurse. I'm an ER nurse. Like, I got to be careful here. This is soft ground. This is soft ground.
Culture's the part of it. We have to talk about it.
So one thing that you hear ICU nurses joke about is, I work in the ICU because my patients are intubated and asleep and I don't have to talk to anyone, And so how do you talk to these nurses about this, right? That we want, because right now in common culture, it would be seen as more work, because I watched that as we opened up that delirium unit. Nurses complain about the orders were to get their patient up and walking multiple times a day for these seniors. And it's a lot, especially when you're in a hospital system that values, skeleton crews and profit and things like that. So how do you talk nurses into this, that we're not all in it for the same reasons, right? So
yeah, I try to hit whatever matters to them. So I think most nurses really do care about patient outcomes. So we're going to talk about that. But at the same time, when I use case studies, I show how much extra work this caused their team. So I get case studies from their own units. So I can break down, this patient should have been off the ventilator on day 2 or 3. Instead, she didn't get off until day 10. Here's how many extra turns that was. Here's how many times a day you were changing the sedation bottles. Here's how many times you were documenting this, that. Look how stressed out you were when she was trying to self-extubate and pull out her tube. Now she's got a stage 3 pressure injury that you get to do wound dressing changes on. Look how depressing that was for your team. Now, how could this have gone better? And in simulation training, we're practicing application of these principles. So now they're now getting someone like that same patient awake on day 1, right after intubation. Now she's awake and strong enough to write on a clipboard. And now I'm saying, how long is that going to take you to understand what she needs? And they say, well, like no time at all. Okay, great. What if you take off sedation in 5 days? Now she's confused. She's too weak to write. And she's really got to tell you something. How long is it going to take you to figure out what's bothering her? And they're like, I don't know if we could. Okay, so what are you going to do instead? And they say, sedate her.
That's the answer that we know.
Right. So I think they're starting to realize that we can work efficiently.
It's fascinating to hear you contrast this, because I think the benefit for us is that because you had to go live a life of frustration, bouncing back and forth between like normal ICUs and the awake ICU, like you got to see the contrast like every day, which is probably has seared it into you. So you can talk through stories and these kind of things and scenarios, unlike almost anybody else can. So I think there's a good chance that you're relating to nurses in those stories, because it's like, listen, this is what it's going to look like. Yeah.
It took your videos. I mean, and not just one, because I was like, oh yeah, okay. When I'm scrolling through, right? Oh, this is nice, whatever.
Good and for you get that
great. another hero out there, you know. But it's the multiple videos, and then the testimonies from patients talking about how they've been intubated, you know, with sedation, and they've been intubated awake, and they will choose awake. And I think when I try to talk about, you know, this to ICU nurses that are friends and ask, you know, what are we doing? Have you heard about this? That's one of the things that I bring up is, well, there's these videos of these patients talking about how they know both ways and they will choose to be awake, you know, if they're intubated. And it's just so powerful, those videos that you have along with the data.
I have a question for you. For those patients who choose to go awake and with ventilation. So as someone who suffers from claustrophobia, I can imagine that having, as you describe it, a leaf blower down your throat is a scary thing to be awake to. So I can kind of see how the choice would be, I want to know nothing about what you're doing to me. I don't want to know about this piping, you know, shoved down my throat. How do you help resolve some of the anxiety that they may have from that part of it?
Yeah, managing that sense of claustrophobia and panic of being in that situation requires interventions that are actually counterintuitive to most clinicians.
Okay.
So when they're panicked and they're like, I can't breathe, sitting them up, especially high and at the side of the bed, getting their back off the bed is so powerful to combat dyspnea. It helps their diaphragm drop. It helps them mobilize their secretion so they can get junk out of their lungs.
Okay.
So that they can breathe more easily. Having their hands free and able to write, that psychologically changes how they perceive the ventilator. So doing normal things like walking normalizes something so abnormal.
Yeah.
One recent little study showed a little microphone onto a BiPAP mask. So those are strapped to your face, so uncomfortable, major claustrophobia with that. They didn't change anything about the mask or the machine, the airflow, nothing. But having a mic so that they could communicate improved their comfort by 20%. So the ability to communicate drastically helps. You can give some fentanyl boluses. You can give Klonopin, like low-dose anti-anxiety medications, without making someone comatose.
Well, and that's because you know to give it, right? So when they're in this delirious state as sedated, now you've got a patient who can tell the nurse, hey, I'm hurting.
Yeah.
Right? And you're guessing before that.
All right. So we've talked about the impact on delirium with sedation and obviously the pressure ulcer issue. What are some of the other positive effects that you've seen from awake and walking in an ICU versus like the traditional approach of chemical restraint? I love that.
One study compared
all the time.
Yeah, one study compared being awake on the ventilator versus doing daily awakening trials.
Okay.
Which many ICUs will just turn off sedation every day to see if they can be off the ventilator. Yeah, right. If that, and then turn it back on. So they think that's like really, really progressive. But in this study, they had them just off of all sedation. The time on the ventilator decreased by 4.2 days.
Ooh.
Time in the ICU decreased by like 1.2 to over 9 days. So huge plus for everyone involved, the fact that they get off. We know that avoiding sedation, avoiding delirium, decreased restraint use by over 60%. So a lot of times we're restraining people, tying them to the bed because they're confused, which worsens their confusion and their agitation, which leaves the restraints on longer. So having them awake right away and preventing the delirium is going to make them less agitated, less anxious. Having them awake allows them to communicate. They don't have the cognitive impairments and fine motor loss. So now that's easier and quicker to communicate their needs and have them met. They're easier to mobilize. Patients develop such rapid muscular atrophy and dysfunction. Here's another thing about propofol that you'll love. not only does it disrupt the brain activity, but it's a mitochondrial toxin, meaning that it is toxic to the muscles. So you're not using your muscles to mobilize, you're using your muscles for energy to fight the critical illness. And now you're giving medications that are toxic to the muscles on top of that. So when you take those three things out of the recipe, they stay so much more functional and they can get themselves to the chair. So many COVID units, if these patients were immobilized, it took just a whole ceiling lift or 5 people to flop them over at the side of the bed. And it was kind of like a weekend at Bernie's experience. But when you have them awake right away, they can stand themselves up, throw their own legs out of bed, get themselves to the chair, walk around the unit with a walker or without a walker. They're just easier to mobilize and they don't require a whole army. It can take a respiratory therapist and a nurse or physical therapist and maybe a family member pushing the wheelchair.
Yeah, I've seen studies.
It's more efficient.
I've seen studies where they've estimated the muscle loss to be as fast as 3 to 5% if you're not in ICU per day. Like it's ridiculously fast.
And then the dysfunction. So you have mitochondrial damage. So you don't just start exercising and regain that muscle. It's damaged. And that can be a chronic disability.
Yes. Yeah. Well, and that goes to a whole host of other. She's smiling because we talk about mitochondria all the time.
I wrote a song about it.
But yes, the fact that we have drugs that are negatively impacting the mitochondria has a whole host of issues outside of even the muscle strength piece.
Well, it's an independent risk factor for diaphragm dysfunction, which you think about. The diaphragm is weakening so quickly on the ventilator. So if your goal is to get people off the ventilator, then preserving their muscles needed for breathing is really important.
Yes.
But now we're not using those muscles to sit, stand, walk. And now we're giving them medications that are toxic to those vital muscles for survival. And that's how a lot of people end up with tracheostomies because they're going to need weeks to months of rehabilitation to rebuild muscles for the basic function of breathing.
All right. So what percentage of people, and this may be even unfair because this is part of the problem with research studies too, is there's multiple variables in everything. And so I don't know if there's a way to track this or study this, but is there a way to show improvement, or is there a number that shows improvement of those who need a long-term ostomy or a tracheotomy versus those who can get off? Have you seen that different with the awake? I don't even know if I'm asking the right question this way. You know what I'm saying?
Well,
I think you're avoiding them, right? Completely.
Yes.
Yeah.
Before COVID, about 6% of all critical care patients had tracheostomies. And I think a lot of that is because of, you can have brain injuries. You can have certain things that absolutely require tracheostomy. There's no other way around it.
Okay.
A lot of our tracheostomies during COVID and now are because of loss of muscle mass and function.
Okay.
So those are very different indications. So when you keep the muscles intact, you're going to avoid a lot of tracheostomies. So in my Awake and Walking COVID ICU, there were very few, like less than 10 tracheostomies throughout the entire pandemic. Whereas most ICUs, almost all of their survivors, if they had them, had tracheostomies.
That's okay.
And were sent to a care facility.
That's a terrible way for me to phrase that question, but you answered exactly what I was looking for.
Because at day 7, you're looking at a trach, right? And at day 5, your case manager is saying, are we looking at a trach? And at day 7, you're looking at whether or not the patient will need a tracheostomy because we've talked about how those muscles decline so quickly.
Yeah.
And if you're shaving 4 days off of their ICU stay, they're not there for 7 days,
And we see in the research that outcomes are improved with earlier tracheostomies. And I have a lot of thoughts about that because what we culturally do is once they have a tracheostomy, now we're like, well, now we got to get them to LTAC. Now we got to get them out. So we can't send them on sedation on LTAC.
Yep.
So we turn off sedation sooner. So there's this whole mental and cultural mind block of it's unsafe to mobilize them with a breathing tube. Yeah. Once they have a tracheostomy, we can now take sedation off and start to rehabilitate them. So it's not the tracheostomy that's improving outcomes. It's the timing in which they are getting patients off of sedation and starting to mobilize them.
Yeah.
So I told families sometimes during COVID, if their loved ones were in other ICUs, I said, if they won't move them until they have a hole in their throat, cut a hole in their throat as soon as possible. Because it'll get them off sedation and mobilized sooner. Yeah. That's what it takes. I guess that's what they don't need a hole in their throat.
Right.
Now, up and moving.
I know you still,
it's just all in their minds.
You still practice some. I know most of what you do is training education, right? Is that right? You still do some practicing though?
Nope. If I'm at the bedside, it's walking them through their own patients.
I gotcha. Do you have family members or like patients ever reach out to you to find out like, hey, how do I navigate this in my current hospital?
Yeah, I do have a little podcast for families.
Okay.
Because it felt like I was harboring this dirty little secret. Put it out in 2022. It's kind of during COVID. So it's a really hard thing to navigate, to not foster mistrust, but you also have to be honest, and we're not. We don't provide this information to families.
Okay.
We don't do informed consent. We don't give any kind of information. They go home. They have no idea what happened to them, let alone anticipating what's to come, let alone being able to fight to prevent it. So I do. I haven't done a lot with marketing it or anything. I have a bigger impact focusing on the critical care world.
For sure. Sure. Okay. Awesome. How would somebody get in touch with you? I know we've connected with LinkedIn, so I know you're on LinkedIn. Leslie's connected with that way too. How would somebody get in touch with you? If there's a hospital that's local here that wants to get in touch with you and kind of learn more about that, or if family members or patients are like, hey, the next time this happens, we need a better option.
# turn my sedation off.
My chemical restraint. Yeah.
Yep. Save my brain, save my body. They can go to DaytonICUconsulting.com.
Okay.
And there it has information about my services. You can schedule an appointment with me, email me. There's all open access there.
That's awesome.
So many questions. I could talk to you for
could
another
do this
5
again.
hours.
We probably need to. I have a lot of questions on this. This has been great. Thank you so much, Kaylee.
Thank you, Kaylee.
Awesome.
Gladly. Thanks for helping with the revolution.
Absolutely. Yeah. All right. Thank you.